Hello everyone, thanks for coming and watching the video today. We're going to be discussing lung cancers. So what we'll begin with is just kind of quickly talking about the common locations for the lung cancers. So here we have obviously a lung, here's a trachea and the bronchus splitting up and going into the smaller bronchioles till it finally gets to the alveoli. And so first we have central tumor, so right there in the bronchus, and this actually extends all the way down. So any tumors located in these areas are considered central lung cancers. And the most common that you'll find is either going to be the squamous cell carcinoma, and the other one is going to be the small cell carcinoma. And a great way to remember this is they both start with S. So if the lung tumor starts with an S, it's in the central. And so if you don't have the central, then you can have a peripheral. These are kind of found in the smaller airways, the bronchiola, and I'm kind of highlighting it there. And it can also be in the interstitium. And so what you tend to find there is going to be either adenocarcinoma or large cell carcinoma. And a quick way, just to go over real quickly, all these four tumors are divided into two groups. On one group, it's going to be the small cell carcinoma all alone. And in these three groups, the squamous cell carcinoma, the adenocarcinoma, and the large cell carcinoma are all called the non-small cell lung carcinomas. And the reason why they do this is because the treatments are much different. Small cell carcinoma tends to be responsive to chemotherapy. These aren't, and so they just need surgery. So that's pretty much the reason they've done that. So let's kind of talk about the how common these tumors are. As you can see, adenocarcinoma is taking up a majority of this pie chart, and adenocarcinoma represents almost 50% of the tumors, and then you have small cell carcinoma 20%, and squamous cell a little bit less. Overall, lung cancers are increasing, associated with the prevalence of smoking, and adenocarcinoma is increasing more than the others. It used to be squamous cell carcinoma that used to be the most common. Now it's adenocarcinoma, and one of the reasons for this is they say they added the filters to the cigarettes, and because they added these filters, there's smaller particles, and they can get further into the lung, and since adenocarcinoma is peripheral, that's why you have an increase of adenocarcinoma these days. But as you can see, non-smokers for adenocarcinoma still very common. So if you're a non-smoker and you get a lung cancer, you most likely have adenocarcinoma. So adenocarcinoma is the most common in smokers and non-smokers. Lung cancer is very common. It is, let me see. Okay, it's the third most common cancer in the world, and it's also the number one common cause of cancer deaths. So it's a killer. So let's focus now on risk factors. What can cause lung cancer? Number one is smoking. Up to 85% of lung cancer is caused by smoking, and also secondhand smoking, although it's not as common, it can cause it. Asbestos can increase your risk of lung cancer by 5 times, and if someone's exposed to asbestos and they're smoking, then it increases it 80 to 90 times. So very high if they have both those risk factors. Radiation, in particular. People exposed to radon or uranium, these patients tend to be at risk. Certain chemicals, arsenic is one of them, chromium and nickel, these patients tend to be at an increased risk for lung cancer. Genetics tend to be a factor as well, so family predisposition. A scar that's formed in the lungs can lead to lung cancer, and these scars are generally formed either by some type of granulomatous disease, or it might be fibrosis or scleroderma. That's another one that can cause a scar in the lung, and then that can proceed to lung cancer. Air pollution, so certain pollutants are linked to increased risk of lung cancer. And finally, HIV, and that's because HIV, as you know, is an autoimmune disorder, and immune system does help fight cancerous cells. So if you have HIV, you can't kill off those cancerous cells as quickly. Okay, so now that we've kind of looked at some risk factors, we can look at the clinical aspect. I break the clinical features into 3 columns, one being the pulmonary symptoms, the next being the paraneoplastic symptoms, and finally the symptoms related to the metastasis. So the first pulmonary symptom that you'll have is a cough, and so what happens in these smokers is about 50 to 75% of patients who have either small cell carcinoma or squamous cell carcinoma present with a cough. And anytime you get a new cough in a smoker, you definitely want to put this into consideration that they might have lung cancer. The other one is going to be hemoptysis, which is a fancy word for coughing up blood. And a common problem with this is it can lead to asphyxia if the blood isn't coughed up completely. Chest pain is also another presenting feature, most common though in the young patients, and commonly described as a dull type of ache, type of pain that they have. Now, some patients will have dyspnea. The tumor itself doesn't cause dyspnea, but it can cause certain conditions that lead to dyspnea, and this could be pneumonia is one of those conditions. Also, atelectasis can lead to the dyspnea, and perhaps they just have some type of lymphatic tumor spread. So the tumor spreads into the lymphatic system, and that can cause this dyspnea. Pleural effusions is another one, and finally, it can even lead to pneumothorax. So these will all be different causes of dyspnea in these patients. Hoarseness is another common condition, and this just means the laryngeal nerve is involved, and most commonly though it's a recurrent laryngeal nerve. And so if a patient has hoarseness, it probably means that it's invading into these nerves. The next is going to be pleural effusion. Pleural effusion in lung cancer can be caused by different reasons, and so you can have pleural effusion which are serous, it can be serosangiounous, or it can just be outright bloody. And this pleural effusion can either be caused by metastasis into the pleural fluid, and if that's the case, that's a pretty poor stage, and so much so that you just do palliative treatment. So anytime you have metastatic cells in the pleural fluid, it's just palliative. However, you can have pleural fluid which is more benign, and if it's benign, that probably means that it's spread into the lymphatic, and that's causing blockage, which leads to pleural effusion, or maybe it's caused pneumonitis, and finally, it could have also caused atelectasis, which is causing a secondary pleural effusion. So you need to keep all of that in mind. Finally, but the next one we'll talk about is going to be the superior vena cava syndrome. And in this syndrome, what you have is you have a tumor that spreads into the superior vena cava. So I'm going to highlight this. So here's a tumor, so it's kind of a central tumor, and it's invading into the actual superior vena cava. And so you're going to get symptoms related to backflow of the superior vena cava system. So when you have this tumor into the superior vena cava, it can lead to very characteristic symptoms. And so here you have a patient who has superior vena cava syndrome. And so what you'll notice is, first of all, if you look at the face, it's very edematous and it's very red. So that's of course because of the backflow of the blood. And if you look at the chest here, you can look at these veins all over the body. They're very prominent veins. And so these are the 2 common types of symptoms that you get in superior vena cava syndrome. So let me actually write this down. So first you can get facial edema and erythema, and you get the prominent veins. And this is more common in the small cell lung cancer than the non-small cell lung cancer. And as we kind of already discussed, small cell lung cancer is a central lung cancer, so it's more likely to hit that superior vena cava. So after this, we can talk about another tumor. It's called a Pancoast tumor. So a Pancoast tumor is anytime you have a tumor that's in the apex of the lung. And so here, I'm outlining the tumor here. So this tumor is in the apex of the lung, and so then it's going to invade into the different structures that are associated with the neck. And this includes a lot of the nerves and the vessels And so the first symptoms that you'll get are related to thoracic outlet syndrome. And this syndrome is characterized with pain and weakness in the shoulder and in the arms and in the fingers and the hand. The next is going to be, they can get Horner syndrome. And Horner syndrome is what happens when the sympathetic nervous chain that goes up to the neck and to the face is blocked. And so you get three characteristic symptoms: meiosis, which is the pupil of the eye contracts and becomes very small; anhidrosis, which means that on one side of the face they won't sweat because sympathetic nervous system is involved in sweating. You don't get that. And finally, ptosis, and this is because again, sympathetic nervous system is responsible for keeping your eye open. A good mnemonic for this is MAP, M-A-P, to help you memorize those three symptoms of Horner syndrome. So keep in mind, a lot of times this patient comes with Horner syndrome, it might be due to a Pancoast tumor, which is a tumor pretty much in the apical part of the lung. So those are all the, and real quick, this is more common in the non-small cell lung carcinomas. That's because, it's peripheral, and as you know, adenocarcinoma and large cell carcinoma are peripheral as well. Okay, so now let's move on to the paraneoplastic syndromes. So the first and most common paraneoplastic syndrome is hypercalcemia, and this can be due to release of a hormone, the parathyroid release related protein, which acts like parathyroid hormone, and so it's going to activate, it's going to increase the calcium in the blood. You can also have bone metastasis, which leads to hypercalcemia. Calcitriol can be released, and also there's certain cytokines that are released which are associated with increased calcium level. Unfortunately, if you do see this hypercalcemia, this is a poor prognosis, as usually it's related to stage 3 and stage 4. So you don't see these stages early on. Next, we can have syndrome of inappropriate ADH release. And so when you release this ADH, this causes the body to conserve too much water in the kidneys. And so generally associated with small cell lung cancer. And so this leads to hyponatremia, which can lead to cerebral edema. So very, very serious. And this can lead to anorexia of the patient and oftentimes nausea and vomiting. Luckily, when patients start chemo, which is common for small cell lung cancer, it resolves with chemo, or you can treat it with demyclocycline or other kind of changing the electrolytes and all those things. The next is going to be a syndrome called Lambert-Eaton myasthenic syndrome. Mnemonic is LEMS. And so this is a autoimmune condition where you have autoantibodies against calcium channels that are located at the neuromuscular junction. So these will affect the proximal muscles, so you'll get proximal muscle weakness. And so whenever you have proximal muscle weakness, one of the first symptoms that you'll have is you'll have difficulty rising out of chairs and going upstairs. It does affect the eye, and by the way, this is really close to myasthenia gravis. Myasthenia gravis causes that drooping eyelid. This won't cause a drooping eyelid, but it does have other effects on the eye, such as vision, double vision. You might get drooping, or you have problems with swallowing. You do get hematological disarrangements. This is going to be anemia. You also can get leukocytosis. You can also get thrombocytosis. Oh wait, 1 second. Okay, 1 second. Not cytopenia. Let me erase this. You get thrombocytosis. Okay, and of course this is going to lead to hypercoagulability. So you got increased coagulation factors, which can also, make them susceptible to formation of thrombi. Another condition that's possible to get is hypertrophic osteoarthropathy. And so this is a triad of symptoms that you'll get. The first one is going to be digital clubbing. So you get clubbing of the fingers. You can also get periostitis. And it's also common to get arthralgia. So they'll get like arthritis and joint pains. So here is a picture here. You can see the you have the clubbing of the fingers, and then there's the bones on the bone scan. There you can see that you have periostitis of the tibia there. Okay, so finally you can get Cushing's, and this is just due to ectopic ACTH production. And these paraneoplastic syndromes are most common in the small cell lung cancer, and that's because the small cell lung cancer is associated with a neuroendocrine origin. So you'll get that. Okay, so now we can have symptoms related to the metastasis. So first of all, let's talk about where it metastasizes to. These conditions can metastasize to the liver, adrenal glands, spine, and other bones as well, and it can also metastasize to the brain. So these are the most common sites of metastasis. Liver, they'll generally be asymptomatic, and the only way you'll find out that they do have this is through liver function test. Adrenal gland as well, rarely symptomatic, and the only way you'll be able to find it is on a PET, which we'll discuss in a little bit. If the spine's involved or any other bone, you'll get bone pain, and they also have increased alkaline phosphatase enzyme and also have hypercalcemia. And finally, if the brain is involved, you get symptoms associated with the brain, such as headache, sometimes visual symptoms. If you get raised ICP, that can lead to vomiting, of course. Hemiparesis, if it affects that part of the brain. Seizures. And this is more common with the adenocarcinoma and not so common with the squamous cell carcinoma. Now, the best way to screen for these metastases is called a PET-CT, and what this is they have they give a patient glucose, which is labeled, and because these tumors are growing so much, these tumors tend to take up more glucose than other cells, and so then by looking at through a CT, you can kind of see where these metastases are. So here are a few images here. So we have two images here. Here you can see where the arrow is pointing. It's bright red, and so that means it is a high uptake of glucose there. And so this is spinal metastasis. And here you can see that there's been metastasis here, and this is an adrenal metastasis. So we're kind of already talking about some investigations. So let's kind of talk about more generalized what type of investigations you might want to run for a patient. The first investigation that you want to do is probably an X-ray, and the classic sign of X-ray is going to be a coin lesion. And so here's an X-ray here. So as you can see right there, you have a coin lesion, very, very circular kind of lesion on its own. 80% of the time, this is going to be a malignant type of mass, and that is actually more higher in smokers. So if you got that coin lesion, you're pretty much thinking tumor. So if you see that, what's your first step in management? Actually, to save a lot of time, what you can actually ask the patient to do is if they have an older X-ray, 1 to 2 years old. And so what you can do is you can compare the size, and if it's the same size, then you can pretty much rule out cancer. But if it's gotten bigger since the past 1 or 2 years, then yeah, you pretty much have cancer there. Once you see that coin lesion, when you're thinking cancer, one of the things you can do is you can do cytology. And so the first thing you want to do is you want to try cytology of the sputum, and you want to look for these abnormal cells, especially in squamous cell carcinoma, as we'll talk in a little bit. But if you don't get anything on sputum, you might want to try bronchoscopy, and this is more commonly done if there's a central type of lesion, and you can do percutaneous biopsy if it's more peripheral. You can also, to get a better look, you can try doing a CT scan, and of course you might want to even do a PET CT, to look for those metastases and help in staging. Okay, so now that we've talked about investigations, let's talk about each tumor or type of cancer individually. So we have small cell lung cancer here. We'll put adenocarcinoma in this column. Here, we'll make a new column for squamous cell carcinoma, and finally, large cell carcinoma. So first what we'll talk about is the distinctive feature, which is cytopathology. As you've kind of noticed, when it comes to symptoms, clinical findings, and even investigations, you can kind of narrow down which cancer it may be, but you cannot pinpoint which one it is until you do histology. So the most distinguishing feature of these tumors are their histology. So the first one we'll look at is microscopic look at small cell lung cancer. And so as the name implies, you have small cells, right? Also called oat cells. And what these tend to look like is small cells with very little cytoplasm. And these are very reminiscent of lymphocytes. So they tend to look like lymphocytes. And so if you look at these cells here, you can see, if you try to look for cytoplasm, you'd be very hard pressed to find it. What is the origin of the cells? These are neuroendocrine origin. Specifically, they're from a cell that's called the Ferreter cells. And these Ferreter cells are found on the bronchus. And that's why small cell carcinoma is more common in the central area, in the bronchus area, than peripheral. Next, we'll look at adenocarcinoma. And so you can see from this image here that it's very glandular, glandular type of look. And it's mucinous as well. So you have mucus being produced within the cells. And so this is generally mucin positive, and it's also TTF1 positive. This is another marker for it. And depending on how glandular it is, it can be anywhere from low grade all the way up to high grade. So depending on how well differentiated it is and how compact and glandular it is. So next we'll look at squamous cell carcinoma. Here, in squamous cell carcinoma, it's generally due to some type of irritation of the bronchus, and over time, what you tend to get is you get metaplasia, and this will develop into dysplasia, and then this will develop into carcinoma in situ, and then it'll continue on. So we are talking about metaplasia here, and that's why you have it in the bronchus, because that's the site that's more commonly associated with irritation. And so generally that's why squamous cell carcinoma is a central lesion rather than a peripheral type of tumor. This is also associated with keratin pearls, and that's just because it's a squamous cell carcinoma. So here we have keratin pearl right there, and you also get cavitations, and these cavitations are a result of central necrosis as well. So that's also another common feature. Finally, we'll talk about large cell carcinoma. So in large cell carcinoma, of course, the cells are much larger. As you can see, there is much more. Let me make this small, actually. Okay. So as you can see, there is much more cytoplasm. You can small type of nucleus and then large cytoplasm. There's unknown origin. We don't really know where these are coming from, and this is kind of a wastebasket type of column here. When you have a histological sample which doesn't, there's no squamous features, it's mucin negative, you don't see small cell carcinoma. If you can't match it to anything, they just throw into this column. So kind of a wastebasket column here. So next, what we can talk about, another distinguishing feature is where they're located. So make a line here. Okay. So extend this. Okay. So we can also talk about where they're located and how they spread. That's a lot of them have very unique features. So small cell lung cancer we've talked about, and squamous cell carcinoma is central, and adenocarcinoma and large cell carcinoma is peripheral. We've already discussed that. Now with small cell lung cancer, the spread, it has a limited stage, which is LS. This is when you have tumor in the lung and one lymph node, and then you also have an extended stage. ES is when you have spread beyond the lungs. Even though there's two stages, these do tend to have early metastasis, and also small cell lung cancer is not only found in the lungs. You can either have other primaries found in the cervix, prostate, and GIT. So it's kind of an interesting feature there. Okay, so with adenocarcinomas peripheral, they grow slowly. However, they do metastasize early. And there's actually a variant that is important to mention. It's called bronchoalveolar carcinoma, so BAC. And this is a lighter version of adenocarcinoma. It's kind of an in situ type of carcinoma, and it tends to have a better prognosis. Next, squamous cell carcinoma. Early on, they're carcinoma in situ, but then it tends to extend into the mediastinum and hilar nodes. And after all that, after it goes into the hilar nodes, you get late metastasis. So this is considered a little bit late metastasis. Large cell carcinoma, they tend to have late metastasis. So that means that you can try to do surgery to resect it. It's not going to be, you don't need to do chemo. Okay, so now that we talked about that, let's kind of go through each one and just talk about some unique clinical features or otherwise. so unique features. With small cell lung cancer, the unique feature is that it has a lot of paraneoplastic cells syndrome. And this is because, again, we talked about how it was a neuroendocrine origin. So it can either be releasing ACTH, SIADH, syndrome inappropriate ADH, cortisol, and it can also cause that Lambert-Eaton myasthenic syndrome, which is associated with the autoimmune condition. Adenocarcinoma, it's associated with non-smokers. It's the most common one in non-smokers. And even within the non-smokers, the most common one is going to be the bronchoalveolar carcinoma. So that's an interesting thing that you need to remember there. Squamous cell carcinoma tends to be, we talked about how it's early CIS, carcinoma situ, and it tends to be asymptomatic at that time. And the only way to diagnose at that time is you can actually do a sputum cytology. And these also associate with atelectasis and infection because they're very high up. And finally, with the large cell carcinoma, these are decreasing in incidence, and this is because there is more advanced staining methods, and so we're starting to find that actually many of these were just advanced squamous cell carcinoma, just difficult to differentiate. Okay, so next what we'll talk about is the management. And so with management, I've kind of talked about this earlier. The reason why they're broken down into small cell cancer and non-small cell cancer is, so here we have the small cell cancer and the non-small cell lung cancer. And so the reason why it's broken into that is because the management is different for both of those. So in small cell lung cancer, usually there is metastasis early on. And so if you have metastasis early on, surgery is definitely not an option. You cannot do surgery on these patients because of the metastasis. So generally, they do respond pretty well to chemo. The platinum ones are the best, like cisplatin and carboplatin, but vincristine is also used. And generally 15 to 30% of patients who take this actually have complete remission. So it does respond fairly well to chemo. Next, what you also want to do with these patients, because brain metastasis is so common, you want to do prophylactic cranial irradiation. Studies have shown that this is beneficial. And so what you're trying to do with PCI is you're trying to prevent brain metastasis. However, oftentimes due to this treatment, they will tend to have hair loss and fatigue. Now, you could do surgery if the tumor is very small and there's no lymph node metastasis. So if it's really small, then surgery is still possible if you catch it really, really early. Now, for the non-small cell lung cancers, these are not responsive to chemo or radiation therapy. So your only option is to do surgery. So we're going to look at surgery. So here we have different lung, locations of tumors and the different types of surgeries you want to do depending on location. And so as we go from here all the way over to the last one, you can see that the tumor is getting more central and central. So if you have a tumor which is peripheral out here, okay, my battery's dying. So if you have a tumor that's out there, what you can do is a wedge resection. So you can just take out a small part. However, if it's lower, you might want to do a segmental resection. If it's more central, you'd want to do something called a lobectomy, where you take out the entire lobe. And if it's kind of in the bronchus, then you have to take out the whole lung. And that's called a pneumonectomy, when you take out the entire lung. However, you can't always just do the surgery right away. There are some things you do need to take into consideration. The first thing is pulmonary function. So you do need to assess the pulmonary function of the patient. If they have, especially if they have COPD or they're experiencing shortness of breath. And this is because if they don't have good lung function and you take out part of their lung, then they're not going to be able to breathe well with the amount that's left over. And so the minimum FEV1 value has to be 800 milliliters before you can do any of these surgeries, especially pneumonectomy. Also, you want to take a look into if they have any comorbidities, which can prevent them from this type of treatment. So we've discussed all of lung cancers. These are primary ones. Hope you enjoyed the video. See you with a future one. Bye.